Now, Module 2. Module 2 defines, and I think we're going to go through these relatively quickly because they're in your handout, and I think you all have a reasonable grasp of what these entail. But we'll just define the settings for detox as well as treatment services, describe the role of the settings in the delivery of service, and then we'll identify at least 5 issues to consider when you're trying to determine whether someone needs inpatient or outpatient. Those will be pretty easy for all of you. Now, the 5 settings for detox services: doctor's office, freestanding urgent care or emergency room, freestanding substance abuse treatment or mental health facility, intensive outpatient or the partial hospitalization, and acute care inpatient services. One of the ways that we determine what's an appropriate level of care is to use the ASAM criteria. And I suspect that many, if not most of you, are familiar with these. These are the American Society of Addiction Medicine, and there are 6 dimensions that you look at. And if you've ever seen the SIMCA AMS referrals, they target all of these in one way or another. These are the things that would be important in determining where the patient goes. And it sort of makes sense. They're acute intoxication or withdrawal potential. I mean, I need some help. I need help. Help me. So probably dimension 1 is going to be key there. They're intoxicated. Their biomedical conditions or complications, their emotional behavioral complications, their readiness to change, relapse or continued use or problem potential, and the recovery and living environment. Now, setting 1, physician's office, ambulatory detox without an extended on-site monitoring, trained clinicians, medically supervised, detox and referrals in the perfect world. Patients are regularly monitored. Patients must have positive social support. Services delivered in office, treatment facility, or patient's home. This is ambulatory detox with extended on-site monitoring, services by RNs or LPNs, medically supervised evaluation, detox, and referrals. Patients are monitored for several hours each day. This is a bit of a step up from the previous one, but both in physician's office. And the physician's office could work in association with a social setting. So it doesn't necessarily have to be in the waiting room or in the examining room. Patients must have positive or ideally social support and network, and that just makes sense. And services provided in treatment setting, such as a day hospital, would also be under this umbrella. Freestanding urgent care or emergency room. We talked a little bit about this. This is, again, some of the most expensive treatments that anyone can pay for. Why do individuals go to an urgent care center? Because they cannot wait or don't want to wait to see their primary care physician. That's why often patients with addiction go to urgent care center or urgent care center in general. Now, with that statement, anybody see a little bit of a red flag pop up? That's assuming that our patients have a primary care physician. And we're going to talk about how the association of having a primary care physician can actually improve outcomes. Just having a primary care doctor that understands addiction, not that's fueling the addiction. So emergency rooms, patients go to emergency rooms because of a crisis. They perceive that their situation is an acute crisis. And it wasn't in the tip, but I would add, the other reason that people with addictions go to the emergency room is to get more drugs. Yes, indeed. We were just talking a couple days ago about a patient who several of us knew who was a medical student. And you've all heard these stories, but he was opioid dependent, and he was so adept at pricking his finger just a little bit and getting just a little bit of blood in that urine, so that when he went into the emergency room, when there's blood in the urine and you have certain symptoms, which he knew because he was a medical student, then it's suspicious of a kidney stone. And kidney stones can be extremely painful. I had one. And often opioids are appropriate treatment, but he would go emergency room to emergency room all across Southeast Michigan. And an emergency room visit for kidney stones, I mean, if I had to guess, could easily be $5,000, $6,000, $7,000, $8,000, depending what tests they do, IVs and monitoring. So You know, the cost of 2 of those, 2 emergency room visits to get 2 prescriptions for opioids, could probably afford a 30-day treatment somewhere. Yet very inefficient from a cost perspective. And again, there's often very little link from urgent care or emergency room to a treatment referral or linkage. Freestanding substance abuse treatment or mental health facility. These are the treatment centers that we're a little more familiar with. Medically managed intensive patient detox. 24-hour supervision, observation, support for intoxication or withdrawal. Stabilization and facilitation of linkages to other services, often with a multidisciplinary staff. Now, the kudo here is that the degree of effectiveness and the range of support varies significantly in this setting. And also, it is there's a significant variation in these settings' ability to provide treatment for co-occurring medical or psychiatric disorders. Some do, others don't. So obviously, that's important to know. If making a referral or trying to get a person who may have a co-occurring disorder that would require at least monitoring, if not treatment, make sure that where they're going can provide that treatment. This is freestanding substance abuse treatment, residential. These are medically managed or social detox. Again, there's that spectrum. 24-hour supervision and support. They emphasize peer and social support. Staffing credentialed personnel using physician-approved protocols for observation, monitoring, supervision. Medical consultation is available 24/7. Some provide supervision of self-administered medications. If you've ever been to the Betty Ford Center to visit there, once the person is stable after detox and they go to the treatment protocol, they don't actually administer their medications, but they go up to the nurse's station once a day and get their medications. Many facilities that will then refer the individual out to a recovery transitional housing, then they'll be given the medication and it's supervised, but they take it themselves. So that is a factor to also consider. IOP and partial, I think this audience is well familiar with what those are. Regularly scheduled sessions, and detox can be done in this setting. Follows protocols, on-site patient monitoring, links to treatment, and again, staffing, and then the disciplinary team. Acute inpatient settings. Now, these are the medically monitored inpatient detoxes. These are the most expensive. You're going to an acute care hospital setting. And by and large, most individuals don't require this level of treatment. But when they do, I mean, this is someone who has just, let's say they're in a rehab center that has a appropriate detox for most individuals, but they just keep having seizures. Or they have a coexisting medical problem that is so severe they're having chest pain from angina while they're having withdrawal. Then this would be the setting for that. This is obviously the most expensive. And also, you'll often see that some of them have treatment personnel that understand addiction and the importance of linking them to treatment continuation, but others don't. You know, we stabilized you, we detoxed you, go on home and don't drink and drug again. Doesn't work too well for people with addictions. Okay, now, this is a little more interaction and questioning you. When you look at an individual for detox, this is just for detox, not rehab or residential, what things would you look at to determine whether they're appropriate for inpatient detox or outpatient detox? I know you know. That's a little different than I have to get up 3 times at night to drink, otherwise I just can't function. So
acute withdrawal.
The acute withdrawal, yeah, the withdrawal. How severe is the withdrawal? You know, what are they withdrawing from, right? Substances. Yes? Did I lose the mic?
No, black marker.
You can't see it too well? I can, there's a request to put the black marker up there. Let's try that, huh? So So we'll put it over here. Withdrawal. That's better. See, it's a thin. How severe is the withdrawal and what substances are they withdrawing from? Anything else?
The health issue, yeah, overall health.
Overall health. They're co-occurring. And we talked about those too. Co-occurring and psychiatric or physical. Anything else? I'll give you some. Environment, the home environment. Like if they're at that frat house, even if the withdrawal isn't too severe, that's a risky environment. Their environment. See, some of you were paying attention. You know this already. Environment. How about if you're sending them outpatient and it's 11 miles away? Transportation. And back to finance and insurance.
Childcare.
Childcare. Whoa, very good. Do you work with women and children? See? She says childcare, and that's very appropriate too. So I think you hit them all. Childcare.
And they have homeless issues.
Home. They may not have a home, and I know that was that always amazed me that when we would call for authorization, for insurance, and the insurance company, would say, well, we can't cover that. It doesn't meet criteria for inpatient. They're homeless. So all of I think you hit every single one of them. Support person, severity, withdrawal. Be right. You got them.